So these are my disclosures, and one of the things I'd like to say is that I am going to be discussing a couple of products that are not in standard use of care. They're still in clinical trials. So a lot of this has been discussed. So what are our objectives today is just the review of the need for immune tolerance, our case studies, and the new products I want to discuss. And then, because a lot of these things have been discussed, this is the last session, over the course of this week, so I've kind of tweaked this a little bit now to, because this is a nursing session, is to talk about some of the nursing implications. So again, as in the last two speakers, usually it's in children. I am at a pediatric center, so I do see a fair amount of these, unfortunately. But what do we need? We need the commitment, which we've just talked about. We need it from the parents, we need it from the patient, we need it from the staff. Everybody's got to buy into deciding when to do ITI. And sometimes it takes a lot longer. It's not an immediate decision. Venous access, infections, are a big issue. When to start, as we just discussed in the last two sessions, under 10 or wait and do it immediately. And then what if they fail? What do you call failure? How many times do you try? What immune modulations do you add? When do you stop and say, okay, enough is enough? So what if there is something else? And that's on the other side of the coin to say, maybe there is something else out there besides ITI. So my case in point is for this case study. So this little boy will be 2 in June, and when he was diagnosed with a bleeding circumcision, the mom could hardly even say hemophilia, let alone know if she had any family history. Although he had a unique last name, and I knew this family, because when you've been around for a very long time, you know several generations of the family, and I knew that this family had a history of inhibitors in it. And sure enough, it did pan out that they were related. He did get 2 exposure days at the time of the circumcision because he was bleeding so much. He did get treated again at 11 months for a soft tissue bleed, and then at 15 months he got 2 for this ankle bleed. And so we did an inhibitor on the first day before we treated him, and came back. Of course, it doesn't come back immediately, so we treated him, and then the next day we treated him again, and then the initial inhibitor came back as 2, and then when we did it again the next time, because he had received an additional exposure day, it was up to 4. So we discussed the ITI with mom, and she said, okay, it's a young single mom, so she didn't know. So I scheduled his port placement. So the day of surgery, I went down there to give him his Novo before the surgery, and as you can see from this middle picture here, yeah, that's what he looked like. And I thought, oh, there's no way, because, all of you that do toddlers, where do we put the port? Here. Where does their nose go? Here. So it's just one big area of bacteremia. So I canceled his port placement. So over the next several months, we tried to do it again, put it in. I'd call the mom and check, oh, how is he? I'd bring him in, still mucus coming out of his nose, as any, little toddler would be. So the physician came in the office one day and we said, okay, what am I going to do? Keep scheduling this? Is there something else we can do? And he said, we can put him on the new product and wait until he's older to do immune tolerance. And we were like, yes. So we did. We put him on the new product, Hemlibra, which is, since November of 17, is licensed in the U.S. It has here the FDA indications for factor 8 patients only with inhibitors. It's a bispecific antibody that bridges the activated factor 9A to 10, and so it, of course, takes the place of the factor 8 that would bind in here. So again, I mentioned something about the nursing implications. We did do the clinical study for this product at our institution, and so there's a few takeaway messages. I'm not going to discuss clinical data. That's been in all the previous sessions this week. But there are a few things that I'd like the nurses to take home. One is that there is the recommended dose of 3 milligrams per kilo is for a loading dose, once a week for 4 weeks. And in a session earlier this week, Deborah from the UK talked about sub-Q injections. And so I charge all of you to go back to your institution and find out what is your policy at your institution as to how much You can give a sub-Q injection. Is it 1 ml? Is it 2 ml? And think of this if you're doing it for a child, too. I mean, 1 ml in a child, especially if they're, not real chubby like most of mine are, that still can be a whole lot of volume. So they're going to get a larger volume while they're getting these first 4 loading doses to get them to a steady state. And then it's followed by once a week. The second thing I'd like to point out about this product, too, is that if you were a hemophilia nurse, your first day you were told, okay, you give every drop in that. If you have to what your dose is and there's more in the vial, you just give it all because it's more expensive. But if you're in a country that doesn't have that luxury, you might divide it between 2 patients, even 2, maybe even 3, depending on the assay size. And that's because, what have you been told? It's very expensive, it's like gold, and we don't waste it. Well, in this situation, the product comes as a liquid, so we are not reconstituting it. And depending on how your physician decides to do the dosing, there may be some left over in the vial that you are throwing out. It is not the same thing like, okay, just give everything in the vial because, it's not going to hurt them. So that's something to consider. I wanted everyone to be aware. The other thing I wanted you to know is that the lab testing is not the normal testing. And if you have an emergency room or even surgeons, one time I went down to pre-op and I said, what's the holdup? Oh, we're waiting for his PTT to come back. Really? I have a crystal ball. I can tell you it'll be elevated. Because they still do that, even in the ER. Well, what labs did you do? Oh, I did a CBC, I did this, I did a PTT. Did you take the history and know the child had hemophilia? But anyway, so they're still doing that nowadays. But what you need to know that is those lab results are going to be falsely positive. And so you really cannot look at these results in the same way. And the other thing is, the rumors are not the rumors, but the stories are everybody's hearing what's on social media and stuff. But the FDA did say that in cases where you even still need to use APCCs, because maybe in your country you don't have other bypassing agents, but it is recommended that the average cumulative amount of an APCC not be more than 100 units per kilogram in 24 hours. And if you read through the clinical data or the PI, it will show you that in the patients that did have some of these thromboangiopathy and thromboembolisms, they did have more than this amount, and it had caused problems. So currently, right now, in hemophilia, there is an imbalance between our clotting and thrombotic proteins. So if we could restore, right now what we use is we have standard half-life products, we have the extended half-life, the bypassing agents, and now new products like Hemophilia and eventually gene therapy. So we have these to now balance this coagulation issue. But what if we had a new approach that inhibits part of the coagulation process to restore balance? So this is the other 2 products that I would like to discuss today. So I liked this slide because here it's going to show you the 2 areas that we're going to talk about, the TFPI and the antithrombin. And you can see they're both on the extrinsic pathway and not over here affecting the 8 or 9. So these products can be used with both factor 8 or 9, unlike the Hemophilia, which is for factor 8 patients. So our anti-tissue factor pathway, I've got to get this down. So one of my colleagues, Jim in the audience, gave me an analogy of using it as these 2 products are like they're like the brakes in the coagulation problem. So what can we do to take away these brakes? So in the anti-tissue factor pathway is an inhibitor that negatively regulates thrombin generation in the extrinsic pathway by directly binding and inhibiting the tissue factor, factor 7A, and factor 10 complex, and modulates the coagulation induced by tissue factor. So there are several companies out there that are working on this product too. As I said, it bypasses the factor 8 and 9, potential for oral and sub-Q. Again, as we talked about, look at your policies for sub-Q. And it has the potential for decreasing bleeding episodes in patients. So here is the way it works now. And so if we can inhibit this TF, tissue factor pathway inhibitor, then we will have completion of our coagulation cascade to get a clot. The other product that I'm going to talk about is fitusiran, which again is, is designed to lower the antithrombin with the goal of promoting sufficient thrombin generation to restore hemostasis and prevent bleeding, using this RNI as a way to interfere in gene processing and therefore decreasing the AT3 that's produced in the liver. So again, here is your antithrombin affected, and if we can change that, and then we can get to our blood clot. I found this chart in when I was doing my research by our Italian physicians, Francini and Manuccio, is that it, Manuccio? Anyway, and it does only mention one of the anti-TFPI products that are on the, in clinical trials right now. That's one of 3 that I'm aware of. But you can see the manufacturer, the technology, mechanism of action, dosing frequently, route, they're all sub-Q, and where they are in development. I just thought this was a good summary slide. So now what I want to talk about is, well, what are the pros and cons to these products? Yes, there's new options available for inhibitor patients, but how do you know which product to pick for the right patient? There's a learning curve for all of us. Again, with the Hemophilia, what labs do we use to monitor these patients? How do you know it's working? The patients, how are they going to know what to do? So there's a potential for less bleeds. So now these patients, well, do they know the difference between an inhibitor or arthritis? And we all know that that's a big issue, and especially in our adult population. Improved quality of health. So the con is that, well, now what do I do with myself? A loss of identity. I mean, how many of you have patients that you see pretty frequently because of their inhibitors? They're used to talking to you maybe weekly, maybe more frequently. Or maybe they're used to coming in. Or in the US, we have inhibitor summits. They go to all these inhibitor summits, even though maybe even they're tolerized, because they have an identity of being, I'm an inhibitor patient. So they may lose that identity. Maybe they need to find a job now because they can't get their disability because their inhibitor is under control, or their bleeding is under control. So what happens to them with their work? Maybe a lot of them have been in such a state for so long, they don't even know how to plan for their future. I mean, getting a job. But on the other side, on the pro side, they do have the confidence to maybe get a job and keep it. Go to school. I know patients that have had to drop out of classes. College is not, university is not cheap, and they've had to drop out because, they had a bleed that put them, with an inhibitor 3-6 weeks even out of commission. So what do they have to do now? Now they have the confidence maybe to go and take a whole course and maybe a semester and finish up and get a college degree. Maybe it's our job to try and guide them to computer analyzing or some more of a sit down and not necessarily construction, things like that. So I think we have those issues. And then there's a decreased use for venous access, which we're all pretty happy about. But that doesn't mean that they're never ever going to treat again, because possibly they will have to treat again. So will they lose their skills if they don't treat as often? So we do have a lot of this pros and cons balancing going on, even with these new products. But so, Jen, I'd like to add to your cookbook these other products as potential ingredients for your cookbook. So my question, or my food for thought, is: are these psychosocial issues too much if compared to preventing the joint damage that we get from our inhibitor bleeds? So, think about that. I think we can handle some of these psychosocial issues. And thank you.